Okay, good evening, everybody. Welcome to this session of 45th Comprehensive Course on Echocardiography. We are almost coming to end of this particular training program online. Today, we are going to have a question answer sessions on the congenital heart disease. And before we have exams next time, I would like you to ask some questions if you want to clarify them. I'll try my best to provide the answers for all of them together, but I'll need some time in case some questions which I could not answer at that particular moment. With these few words, let's get going. We have with us many people on this platform today. Many are still resting at their homes, and many of them are enjoying their holidays somewhere else. So to begin with, I'll start calling the names one by one. May have, first of all, Dr. Balram Jonathan Sharma. Balram, any question which you have in your mind you want to ask?
Yes, sir. I wanted a little more clarification. There was one slide mentioning the different morphology of the right atrium and the left atrium, about the appendage being more broad in the right atrium and also the Eustachian, being in the right atrium. Could you show some pictures of that, sir?
Yeah, sure. I'll do that right now. Give me a sec to open up my browser and take out that particular file from that. All right, so I'm done with my so I'll stop sharing this particular slide, and then I share my slides of a congenital heart disease. And in this slides of a congenital heart disease, of course, I should be able to tell you what are we looking for. So I'll start from somewhere from here. All right. Can you see my slide, Balram?
Yes, sir.
Okay. This is where we opened up an IVC and we led to a structure which is most probably a morphological array. And I hope you or somebody else sent me a literature when I said that IVC always opens in RA. That's a fixed dictum. Somebody sent me a literature saying that IVC does open in LA. That's a good way of reciprocating. And I really appreciate that somebody has said that word. And to increase my knowledge also, if this is a morphological RA, then IVC drain into it. Suppose this IVC does not drain into it. How do we identify that? All of us understand that RA will have what? It will have IVC and SVC. On the contrary, it will not have a direct drainage of pulmonic venous flow. Like LA always have an LA appendage, which is seen right over here. And then it has got a pulmonic vein right and a left, which drains into LA. Now, a theoretical question can come where the drainage of pulmonic vein is also aberrant. In that case, I'll still put my bets. The drainage of pulmonic vein is aberrant, but LA appendage drainage or LA appendage shifting to right would be nearly impossible. So in justice, in sense, we say that possibly the drainage of IVC versus SVC in morphological RA, and presence of pulmonic vein and the presence of LA appendage in left atrium justify them as the morphological RA and LA. Is that okay?
Yes, sir. Thank you.
All right. So we'll move to other person, that is Vasudev Utpat Umakant.
Yes, sir. Good evening.
Good evening.
Sir, regarding the various types of ASD, specifically sinus venosus, can you just show some echo,
Sure.
please?
I'll tell you a sinus venosus ASD. So I'll move my slide, the same slides to us varieties of ASDs. So in varieties of ASD, what do we look for? We look for these kind of a varieties of ASD: septum primum, septum secundum, sinus venosus, and in sinus venosus, it could be SVC type or IVC type. It's like I said, sinus venosus ISD, but let me just bifurcate and correct right over here. Its variety like SVC type of ASD, and second variety is of course IVC type of an ASD, which is not easily seen in transthoracic echocardiography. It's seen in transesophageal echocardiography. Looking at these things together, we have one more kind of an ASD, which is known as unroofed coronary sinus. So let me get to next slide. The presence of a fossa ovalis over here is a normal circumstances when we have a direction of blood from right atrium to right ventricle in intrauterine life. When intrauterine life, the patient or the child newborn is born, there's a presence of a limbus kind of a structure which closes this so-called fossa ovalis. If the defect remains in this fossa ovalis, this is known as secundum ASD. If the defect is closer to atrioventricular valves, whether tricuspid or mitral, this is known as primum type of an ASD. On the contrary, if this defect is away from this primum or secundum, then we have a sinus venosus type of ASD. If this sinus venosus ASD is in relation with SVC or IVC, then we call them accordingly as SVC and IVC type of ASDs. Next question comes, what is a variety when we call them as unroofed coronary sinus? This is almost always associated with persistent left side of an left SVC when it comes and drain into a variety. In the sense, normally this SVC will join into right SVC to form a single SVC and drain into the right atrium. However, this connection is lost. It directly drains into the right atrium. And when it drains to right atrium, there is an unroofing of this particular SVC. And when you inject a contrast in the left atrium, a lot of contrast will come to left atrium first, and then it will come to right atrium. And this could be, I showed you the picture of this particular contrast, where this kind of a thing, if seen, is normally associated with dilated RV RA and elevated LVDP. The answer to this is, you give a right-sided contrast, it will come and specify RV RA. You give a left arm contrast, it will come and specify first LVLA and then RV RA. And this is what in transesophageal echo, we look at an SVC type because SVC is over here. On the other hand, we look at an IVC type on an ASD because IVC is over here. So that's how we look at this SVC type or IVC type of ASDs. I hope I'm able to substantiate your answer by showing these few slides. Anything else, Utpat?
Sir, I got this bicaval view of transesophageal echo, but many a times during the transthoracic echo, when we get the four-chamber view, apical four-chamber view, we see some defect which actually anatomically is not present, but because of the perpendicular nature of the probe, we see that defect. But how to get exactly whether it is actually a defect or not, means any other
First of
view?
all, the answer comes in two parts. The first answer comes in the part that the basic principle of echocardiography is if you are doing a Doppler, you should be parallel to the flow. If you are doing an imaging, you should be perpendicular to the flow, perpendicular to imaging. When you're in fourth chamber view, what happens in that fourth chamber view? We are almost parallel in to the intraatrial septum. Here is the answer. Look, this dropout would be very commonly seen when you happen to see an fourth chamber view. Does this dropout always means presence of ASD? Certainly not. What do? Either we switch on a color or we inject agitated contrast saline into the right arm so that if there's a hole in it, it crosses over to other side.
Yes, sir. Actually, means agitated saline is a good option, but this even the colored Doppler, many a times the pulmonary vein flow or the SVC flow comes, which mitigates like it's coming from the LA side or RA side going to LA side.
Okay, fine. If such a dropout is present and RVRA, they are normal size, the ASD is unlikely.
Okay.
And you can go and prove in subcostal window whether there is a defect in intraatrial septum or not.
RA-RV dilatation is a
Right.
correct. Okay, sir. Thanks, sir.
Next, let's move on to Dr. Tushar Kamal Kishore Sharkha. Tushar, are you there? All right. Dr. Tiam Banikyu. Dr. Ghansham Motisaria.
Yes, sir.
Go ahead, Ghansham.
Sir, we have seen situs solitus with D loop, but we have not seen situs solitus with L loop. Can you have any slide of L loop?
I don't have a slide for that, but when I'm doing a live demonstration, I showed you that slide. Let me just give me a chance to produce situs solitus with L loop. Let me try. I should be able to do it. Because these computers are very handy in that fashion, you know. Let me just try to do it, and if I am able to do it right.
This is D loop.
This is D loop, okay. So I'm just holding this image, and if I'm able to rotate this image crosswise, yeah, I'm able to do it. Now, this image rotates as such. Imagine this left ventricle is towards the right ventricle.
Yes.
That's all. I showed you live demonstration.
Okay, sure. And second question is there any surgical correction of Epstein anomaly? If yes,
Certainly, Epstein anomalies majority of time is surgically corrected only. The reposition of this tricuspid valve leaflets.
okay. And is there any criteria patient if asymptomatic then?
Well, if the
Because
patient,
of many times we see
patient is
that.
asymptomatic, nobody would like to do anything.
Okay.
In whatever you say, whether it's a Epstein anomaly or whether something else also, if patient is asymptomatic in any illness, we'll think 10 times before doing any interventions.
But sometimes patient as is going up, patient becomes symptomatic. For example, 35, 40 years. So it is advisable to correct earlier or when he is symptomatic.
As soon as somebody becomes symptomatic.
Okay. Thank you.
Thank you, dear. Thank you. Let's move on to the next person, Dr. Damodar alias Swapnil Arsekar.
Hello, good evening, sir.
Good evening, Damodar.
Sir, you had explained how to identify the morphological array from IVC, and you said that eustachian valve and membrane and Chiari network may be seen.
Correct.
Then, sir, you stressed upon that we should gradually move the transducer from that point, from the subcostal window to the apical window.
Right.
That I didn't understand why. That I didn't understand.
The answer, let me just show that slide to you. The question is, we go for a transverse axis almost 90 degree. When we
Yes.
angulate anteriorly, IVC gets opened up, and this is so-called a morphological RA. Now, in this morphological RA, in this subcostal window, I cannot look at my LA. So what I do, I start looking at this morphological RA, keep an eye on it, and move my window from subcostal to apical window. And in adults, it could be difficult, but in neonates, it's not difficult at all. So that this structure is identified as morphological RA, then other structure is obviously a morphological LA.
Okay, sir. And there's one more question, sir. You had said regarding VSD that you have to not measure the size, you have to measure the gradients. And you had said for VSD, sir. VSD.
Right.
So higher the gradients, good is the VSD. Lower the gradients, poor is the VSD.
Bad is
So,
the VSD.
so poor means bad, no, sir?
Bad. Bad in the sense, what do you mean by higher and lower gradients are? If I'm an adult, you and me have a blood pressure of left ventricular is 120. Correct?
Yes.
What is the right ventricular pressure? 25 millimeters of mercury.
25.
So let's, for a simple sake, LV pressure is 125 and RV pressure is 25. So what is the pressure difference between these two?
Around 95.
95 to 100. Let's make it 100. Okay. And if it's 100, if we transform this 100 into velocity, what would be the velocity?
Four into velocity square.
So we divide by 400, that gets to 25. Square root of 25 is 2.5. Not 2.5, 5.
5.
So the velocity across LV and RV is 5 meters per second. And hence our TR gradient is almost negligible. Now let's see the second thing. When the gradient is only 50, so where the rest of the gradient goes in? It is manifesting like pulmonary artery pressure, elevated pulmonary artery pressures. So that 50 is reflecting as TR gradient with the 50 millimeters of a pulmonary peak pulmonary artery pressures. So if the gradient is low, pulmonary artery hypertension is present. If the gradient is high, pulmonary artery hypertension is not present.
Okay. So it is going somewhere else and creating a pulmonary hypertension.
Right. It means the pressure between LV and RV, they are getting almost equalized.
Yes, sir. Thank you, sir.
All right. Let's get to the next person, Rahul Kenkan. Are you there, Rahul?
Yes, sir.
Go ahead. Question.
Sir, actually, I have a few questions. Sir, regarding the rims, identification of rims in ASD, how do we identify them on transthoracic echo, sir?
Transthoracic is difficult, man. Whenever we do a transesophageal echo, then only we look for rims, you know. Transthoracic is little difficult, but I'll try to explain, you know.
Okay, sir.
This is a subcostal window where we have aorta in the center, a tricuspid valve, then RV, pulmonic valve, and then the pulmonic artery. Here is the subaortic rim in this particular fashion. And here is a defect, and this is RA free wall rim. On the contrary, if you go to other subcostal window, I'll have to go back to my picture. Yeah. If I'm looking at this, that was known as atrioventricular and aortic rim. This is known as atrioventricular and atrial rims. Here we look at this defect, and there is a rim out here. But in 2 dimensions, it's very, very difficult to call them as the exact hole. And when we do these things in transesophageal echo, what we drive the final images? We drive this image by two-click crop method. And by driving from two-click crop method, we get exact rim definitions. So what is the rim is? Like we have an aortic rim because aorta is seen over here. Then we have an opposite side rim, which is known as a cornicinus, or this side rim is posterior rim. Above is SVC type of rim. Here is IVC type of ring, is a cornicinus. But to make it very simple, I always refer this as superior, inferior, aortic, and RA free wall margins. And this we drive from a 3 dimensions echo image. We acquire 4-chamber view. And from 4-chamber view, we acquire this particular phenomena of rims through 3 dimensions. That's all I can say right now, because we have to do a 3D echo to assess the size of ASD and the rims.
So, sir, while giving reports at our level, is it okay if we only mention ostium secundum ASD with the defect size and if we don't mention the rims?
No, you should not mention the rims in 2 dimensions echo.
Okay.
What you should mention the size of ASD in atrioventricular and atrial rim, that is subcostal 4-chamber view, then subcostal short axis view, atrioventricular and aortic rim, aortic ASDs. Let me just tell you like that kind of a picture. If I have got a recording from that, give me a sec. I'll try to find out the report where we have mentioned this particular phenomena of ASDs. Yes, I should be able to share you with that images quality. What we say that in how we say in 2 dimensions. And if it's there in 4 dimensions also, 3 or 4 dimensions, let me just show you that pictures. Yes, possibly you got the correct things. Just hold on for a second. I'll show you everything out here.
Yes, sir.
So I'll stop sharing the slides. I hope you can see my slides now.
Yes, sir.
Okay. So this is, if you look at it, this is dilated RV. And look at the septum, which is bulging towards left ventricle, and it shows a different kind of a motion from a normal subject. So I'm not going to spend time on this. I'm going to spend time. Now here, this septum is bulging, but during systole, it's not really moving into the LV. So this is what is known as atrioventricular and aortic size of ASD. This is like subcostal window where we have rotated our transducer 90-degree counterclockwise rotation and the footprint looking toward the right shoulder. And here is a defect. So we measure a defect from this point to this point to call them as atrioventricular and aortic rim. Aortic size of ASD. Now you can look at an ASD flow in this. Same patient, if we go to the subcostal 4-chamber view, which I'm going to come gradually. So same patient, if I'm going to subcostal window, here is a subcostal window of the same patient. Look, it's very difficult to see the atrial septal defect, right?
Yes,
And
sir.
if you can't see an atrial septal defect in the subcostal window is, what do? Either we do a contrast or we switch over the color Dopplers. And when we do that, so this is known as atrioventricular and atrial view, and this is a side of a defect which we mentioned. But here we are seeing a rim something like this over here. But we can't mention about the rims. We only mention, look, there is a hole which measures it so many millimeters in atrioventricular and aortic view and atrioventricular and atrial views. Next comes when we go ahead and do a transthoracic 3-dimension set. This somebody was asking in the initial beginning. Look, there's a dropout seen over here. How do we prove it? Switch on colors. You will find a lot of blood going from left side to right side. This is more specific atrioventricular and atrial view. This is truly subcostal. So we have a hole out here. So we measure the hole out here. But when we go to 4-chamber view, now this is exactly the view which we look forward. We acquire a 4-chamber view and then we do a 2-click crop method by pushing an arrow from this point to this point. So what we are intersecting in this arrow? We are intersecting the interventricular septum, interatrial septum, and the presence of hole in this interatrial septum. So here you look carefully. This is what? This is tricuspid valve. This is what? This is mitral valve. Just small mitral valve. And we see a hole over here. And when you turn around this hole, this is what the hole comes like. This is just a bird's eye view of a hole. And when we do this kind of a thing in transesophageal echo, as I'm able to do it over here a little bit, this is tricuspid valve. So this is the margin of atrioseptal defect. This is what is seen over here. And this is the hole out here. If I move it in a end-face view, I'll be able to see whole of this atrial septal defects. And when we are able to end-face view, then we see where the aorta is, where the SVC is, where the IVC is, where the RA free margins are. And these are depicted by transesophageal echo very well. No second thought in transesophageal echo. This is what I try to do by utilizing my 2-dimensional transthoracic echo. I've done a 2-click crop method for sitting in LA, going to RV, and this is my hole S. So we're identifying this hole, then I have to identify where is my SVC, where is my IVC, and then where is my aorta. So if suppose aorta is somewhere over here, then this becomes aortic rim, this becomes an SVC ring, this becomes an IVC ring, this becomes RA free margin rings. But to really do a correct method, we do a transesophageal echo and we drive this image in transesophageal echo very well. Look, I have tried to drive this image. If I rotate this image of mine, just hold on, I'm going to rotate this image of mine. So this is a hole. This could be a possible SVC. This could be a possible IVC. Here could be an aorta on this side, and here's RA free wall margins. And we can measure this and measure the rims of all those structures which are seen over here. It's little cumbersome in transthoracic, but we can get a good idea as I showed you in this particular slide. Is that okay?
Yes, sir. Very nicely explained, sir.
Right. Thank you.
So one
Go
more
ahead.
doubt.
Go ahead.
Regarding in Epstein's anomaly, sir, sir, the apical displacement of tricuspid wall should be about 20 millimeter or 8 millimeter.
Okay, let me just go to, let me stop sharing this particular phenomena of slides. So let me find out an Epstein anomaly first from my armamentarium of slides. Congenital heart disease, all cases. So let's look where the Epstein is. Epstein anomaly. Here is an Epstein anomaly. The true figure, if I remember correctly, for Epstein anomaly is 7 millimeter per meter body surface area. So that is the correct picture for any Epstein anomaly, to label them as Epstein anomaly in day-to-day circumstances.
Okay,
So one picture, I'm able to get it. Let me just go through that picture. Give me a second. So it's approximately 7. I cannot locate that slides over here, but it's about 7 millimeters per meter body surface area, which more than that displacement is there. We always call them as an Epstein anomaly.
okay, sir.
Anything else, Rahul?
Sir, and one last question regarding what all views should we use for identifying PDA, and how do we take the gradient, like the apart from the short axis at aorta level?
So I'll go back to my presentation. You can see my slides now, right?
Yes, sir.
You're talking of PDA or a coarctation of aorta?
PDA, sir, PDA.
So the most common view of PDA is parasternal short axis view at aorta. Here is aorta in the center, and here is the regurgitation flow, correct? And second is what we call them as a ductal view. This is ductal view. If you happen to see this ductal view, this is how do we form it? You go to parasternal long axis view, right? When you
Yes.
tilt your transducer toward mediastinum, what view you get?
RA, RV inflow.
Correct. So you tilt your transducer away from a mediastinum.
Okay, sir.
So
Hmm.
once you tilt your transducer footprint away from mediastinum, what you'll get? You'll get a ductal view where this is descending aorta, here is a pulmonic artery.
Okay, sir, do we go in a one space, one intercostal
We
space
can go
above?
one space up also. If you can't, we just go one space up.
Okay.
And then you can measure the size of this ductus from here to here. And the flow of ductus is constant. The flow of ductus is not partial. When there is a constant continuous flow of a ductus, then we call them as PDA, and we measure the gradient across the ductus. Like if it's a peak velocity and then the early peaking and late peaking. So the continuous flow will have a pattern. If I can show my one of the slides from that cases, give me a
Yes, sir.
second. No, I can't show you the Doppler pattern of the ductus right now. No, I'm sorry, can't do that at present moment. So maybe like I'll send you that. I'm just writing to send you a PDF flow.
Yes.
As soon I'll send on the WhatsApp group. Sorry, ductal, patent ductus arterius flow. I'll send you Rahul once we finish the class.
Yes, sir. Thank you, sir.
Okay, right. Let's move
Thank
on to Dr. Krishna Ansiram Yadav. Are you there, Krishna? Mrs. Jigna Viresh. Jigna, are you there? I can't see Jigna sitting over here.
Hello.
Yeah, she's there. She's there. Good, good.
Yes, sir. Good evening, sir.
Good evening. How can I see a beautiful female like you have posted an excellent photograph, you know?
Thank you, sir. Sir, I want to say sinus venosus ASD, sir.
Sinus venosus ASD. Okay.
Okay.
Uh, how do you see sinus venosus ASD? I think that'll be the better answer, right? So I'll go to my congenital heart disease and I hope I have that sinus venosus ASD. Coarctation, contrast, ASD, adult 3D Kalasho Amplas device, ASD device, post closure, contrast. So let's see if is there so that I'll be able to show you that sinus venosus ASD. All right, I think Jigna, I am able to give you an answers for this sinus venosus ASD.
Okay.
So how do I give an answer is just let me shorten this down, get rid of this media, then share my slides. Can you see my slides?
Yes, sir.
Okay. So I'm going to make a zoom of it. This is a majority of time what we use in this view where we suspect. When RVR, they are dilated and we cannot see any hole like in this kind of a things. And then we give a contrast. And look carefully, this contrast is coming from this secondum ASD. A few bubbles are coming. But when this, you can't see the source of a contrast, like the contrast comes from somewhere here. And when this contrast comes somewhere over here, then we call them as possibly sinus venosus kind of ASDs. But how do you prove this? Because here also, this is a negative contrast. Look, here is an IVC. Here is an SVC. If you happen to see a hole over here, this is possibly a sinus venosus type of an ASD. But the best answer of this sinus venosus ASD is given not by this particular slides. The best answer is given by this presentation of ASD. when you do a transesophageal echocardiography, this is a like 110-degree view, which we call them as a bicaval view. If you have a hole out here, this is an SVC type of ASD. And if there's a hole out here, this is an IVC type of ASD. So this is the best way of looking a sinus venosus type of an ASD. And you can very clearly, and you can really measure the size of a sinus venosus type of ASD or IVC type of an ASD, the size of these ASDs. We can suspect by contrast in apical fourth chamber or subcostal view. But to confirm, we have to do a transesophageal.
It is difficult to see in transthoracic echo. Sir.
It is sometime in subcostal window, you can, I'm not saying no, because
Yes,
if you go to subcostal window in this particular format, I'll go to that. Yeah. Look, this is atrioventricular and atrial rim, which we was talking about. Here is an IVC. And if you happen to see a hole in subcostal window over here, then this is possibly an SVC type of ASD.
Okay, sir.
It's difficult, but you can.
Okay. Yes. Sir.
All right, Jigna, any other thing?
No, sir. Thank you,
Thank
sir.
you.
Yes.
Mrs. Jayanti,
So she's
Jayanti,
out
are you
of
there?
town. No, sir, she's out of town.
Okay. Ranjit Shankar Mohite.
Sir, can you please explain the VSD subtypes?
All right, Ranjit. Look, the best part of a VSD, what we remember as on today in our day-to-day practices, look, this is how we remember our ASDs. We call them as the most common type is inlet, outlet, muscular, and perimembranous. How do you look for this? These kind of things. If you happen to see a VSD, when my aorta is opened up, I 5-chamber view. This is known as outlet VSD in this interventricular septum. If you happen to see when aorta is closed in for this 4-chamber view, this is known as inlet VSD. Then come muscular VSD. This is all part of muscular VSD. Short axis view, you happen to see a muscular VSD. You can see this muscular VSD both in inlet as well as outlet muscular VSD. Then most common variety is this paramembranous type of a VSD, which is seen in plaques window, and you happen to see a hole over here, that is perimembranous VSD. Next comes a very typical things is, if you look at this perimembranous VSD in parallel short axis view, what will happen? This is a part where you find a perimembranous VSD. This is the part which is known as muscular VSD. This is the part which is known as doubly committed or subaortic, subpulmonic VSDs. So this is how we remember this classification even in 2022 when this was described in 1980. And I've made a diagram over here by myself. So we go to short axis view, look at this perimembranous, look at this muscular VSD, and look at this doubly committed or subpulmonic VSD. This doubly committed VSD is always associated with aortic regurgitation. So if you happen to see aortic regurgitation in your pediatric population, think that you are having an associated VSD. And this is outlet muscular, this is perimembranous. So in turn, inlet, outlet, muscular, doubly committed, VSD and perimembranous. Now the question comes, how will you really scan? So you need a 4-chamber view, you need a 5-chamber view, you need a short axis view, you need the plaques view, and then the parasol short axis view at aorta. So you need 5 views to look for VSD.
Okay, sir. Thank you.
Thank you, dear. Dr. Dalip Bhatkar Pandit.
Yes, sir. Good evening, sir.
Good evening, Dalip.
Sir, what is the precaution while doing agitated contrasaline testing? What precaution we and which patient we should avoid that?
The precaution is very simple. Look at the size of a baby, like suppose you have a child, a neonate, which is just a month and a half old, you can't inject 10 ml for normal saline in that patient.
Okay, sir.
So in that patient, if you want to really do a contrast, only 1 ml would be more than enough. First.
Yeah.
Second is, be careful if there's a large hole and if you inject a contrast, majority of those bubble will come to left circulation immediately. And when these circulation, they come to left circulation, where they'll go? Either they'll go to the aorta, they go to the coronary arteries. If they go to coronary arteries, you'll find bradyarrhythmias and other kind of things. If they go to aorta, the first place they'll go to the brain.
Yes, sir.
So keep your saturation intact. And what we do, we always do a pulse oximeter while doing a contrast. So if somebody develops some complications, we always understand the patient is having bradycardia and hypertension. Next answer come, how to deal with it. That's the more important thing.
Yes,
So
sir.
we all understand, if we jack up the blood pressure by inotropic support like mefentamine or by dopamine or by steroids, whatever it is, you jack up the blood pressure, they'll go to the peripheral circulation and your insult because of air embolization will go away completely.
Okay. Okay, sir.
All right.
Yes, sir. Thank you, sir.
Thank you. So next one is Dr. Dinesh Tiwari.
Sir, I want to see the inlet and outlet VSD slides.
Inlet and outlet VSD. Okay, let me try to look at this. First of all, see this muscular VSD.
Yes.
Switch on the colors. This
Yes.
is inlet muscular VSD. So this is inlet. We do not have outlet. So this is inlet muscular VSD. And if you switch on the colors, you'll find a flow. This is the muscular part of a septum, and this is inlet muscular VSD. So if there's a VSD which is present with this inlet, this is known as inlet muscular VSD. This VSD will be seen again in cross section of parasolic short axis view at mitral this papillary muscles. So again, the same thing which is seen over here. Now, instead of this inlet, it has become an outlet muscular VSD. Here is an aorta. So this becomes outlet muscular VSD. This is perimembranous VSD. If you look at carefully, this is perimembranous VSD and a large hole of a perimembranous VSD. And if you look carefully, there is a bidirectional flow of perimembranous VSD. So this is known as perimembranous outlet VSD. Some people also call them as perimembranous outlet VSD. And this is again confirmed by doing a short axis view at aorta to look at perimembranous outlet VSD. If there's a VSD over here, this is muscular. And if there's a VSD over here, is doubly committed or subpulmonic VSD. This doubly committed or subpulmonic VSD will always be associated with vegetations. So here I have measured it. Now we should not measure it. We should always take a gradient of these VSDs. Is that okay?
Okay.
Dr. Bhimrao Pawar. Are you there, Dr. Bhimrao? Dr. Rakshit Bhardwaj.
Sir, I'm here, sir. No doubt, sir.
All right. Dr. Ankan Patel. Nitin Gupta. Dr. Hiru Alamin.
No question, sir.
Dr. Nitin, right?
Question, sir.
Nitin, this is you, right? Dr. Sirisha.
Sir, good evening, sir. No doubts, sir.
No doubts, you are all understood very well.
No, sir. I have to go through the topic once again.
Okay, all right, all right. You can go to the recordings.
Okay, sir. Thank you.
Dr. Ganesh Tukaram Thomre. Dr. Sayali Nandkumar Bangre. Dr. Sumant Kumar, Ishwar Agarwal, Anupa George.
No question, sir.
Anupa, good. Amit Kumar Potulwar, Umesh Rajur.
No questions, sir. I have to read.
Yes, even I have to read, man.
No, I have to see, sir.
Okay, great. Dr. Safelia Vishal Sardesai. It looks like everybody has got tired now listening to me again and again. You know. Last week was not there. I was traveling from Gaul in Sri Lanka, from Gaul to Colombo. So I could not get attached with you, all of you. So let's move on to Mitul Jain. Mitul, are you there? Namdev Limbaji Chaure, Suman Chatterjee, Anchula Singh, Rahul Ganesh Rao Gore, Shashank Prabhu Desai, Jai Singh.
No question, sir.
No question, Jai Singh. Okay. Shrikant Rajvilas Gote.
No question, sir.
All right. Vinay Sharma.
Good evening, sir.
Good evening, Vinay.
Hello.
Who is this? Who is this? Vinay Sharma. This is not Vinay Sharma, sir, certainly. Dr. Anudeep Reddy.
Sir, no question, sir.
Vinay, this is you, right?
Yes, sir. This is Anudeep, sir.
Anudeep. Okay.
Yes,
Dr.
sir.
Karanveer Thoughtward. Karanveer. Dr. Madanik is traveling back to his place. Tamogna Das.
Good evening, sir.
Good evening, Tamogna.
Sir, can you show the slide of doubly committed VSD? And sir, why is it called doubly committed?
All right, good question. This is a slide of doubly committed VSD. The part of this VSD hangs into the pulmonic artery. The part of this VSD hangs into the RV. So that's why it's known as doubly committed VSD. So the answer is you go to short axis view and look at this flow over here. If you happen to find the flow from this, suppose this is watch 12 degree. So if the hole is between 11 and 1 o'clock, this is outlet muscular VSD. If the hole is between 1 to 3 o'clock, this is doubly committed VSD. And these are the worst VSD which we cannot close majority of time. They have to go to surgical closures.
Okay, sir.
All right. Let's move to Dr. Durgesh Makwana.
No question, sir.
No question, Durgesh?
No, sir. No, sir.
Kevin
I need
Bora?
to go through.
Kevin, are you there? Ravi Bhushan? Chandar Kumar Roy Mohapatra? Yogesh Namdev Patel? Majrul
No
Islam?
questions.
No question,
Hello,
Yogesh?
sir. No, sir. No, sir. We'll have to read it again and then come.
Listen to it again. You can.
Yes,
We
sir.
have sent you the recordings, you know.
Yes, sir.
Just go to the recording again and again. Chandan, you have any question? You have just joined. Majrul Islam?
Yes, sir. Hello, sir. Good evening, sir. I have a question, sir.
Go ahead. Go ahead.
Sir, a VSD of tetralogy and a normal VSD, how can we differentiate from the VSD of whether it is a VSD of tetralogy VSD or it is a normal perimembranous or other type of VSD, sir?
Okay. Just a second. Look, this VSD is
Yes,
if
sir.
you find this VSD where it's not overriding over the aorta, suppose this
Yes,
comes and opens over here. The hole is somewhere over here. This is the
Yes, sir.
anterior aortic root. This is the posterior aortic root.
Yes, sir.
You remember this picture very well?
Yes, sir.
This is VSD. If there is overriding of aorta, that is a VSD of tetralogy of Fallot.
Yes, sir. Yes.
Is that okay, Majroor?
Yes, sir.
All right. Dr. Nida Farhin Ayub Khan. Nida, are you there?
Yes, sir.
Any question, Nida?
So majority of time, these patients come to us after post-op, sir, in adulthood with no operation history. So how to approach this kind of patients, sir? For example, post surgical VSD closure or ASD closure.
Nida,
Then
it
what
is
are
a
the
very difficult answer question you have asked me. Unless until we have a history of these people, it will be not easy to define them or see them. I can give you a few examples. Let me just stop sharing this slide and I'll show you an example where ASD or VSD has been repaired. Let me just take out those pictures from this. If it's ASD which has got a patch, possibly you see a hyperechoic shadow in these patches of ASDs. So post closure in adult. Give me a second if it's opening over a period of time. Not this. Okay, can you see my slides now, Nida?
Yes, sir. Yes, sir.
So this is a patient of post ASD closure. I don't know why they're not playing, but let me just go to that particular film. Look, if you look at carefully over here, you find this kind of a patch in this post ASD closure people. But you have to have a history, otherwise you cannot decide whether these people have got a post ASD closure or not. This is easy because once you get in history, look at this hyperechoic shadow seen over here. That is fossa vallis defect, which was closed surgically. Okay, Now let me show you something more than this. All right, Nina, can you see my slides now?
Yes, sir.
Look at this slide very carefully. What do we see in this slide? This is Flax window. Here is aorta, here is LV, here is LA. And look at this seen over hyperechoic shadow, which is projecting into the mitral valve.
Mitral valve.
Go to 4-chamber view. This is very clearly, this is oversized MPLAS device.
Yes, sir.
So that's how we pick up these kind of things if we have a prior history. But if we have a metallic device inside, we can pick them without anything. Look at this projection. So prior history is very important. And if you happen to see this kind of a device, we always go back and see what is the abnormalities. Okay?
Okay, sir. Yes, sir. And for any top repair?
Pardon?
Top repair, sir.
Top repair will show the same things, because what will happen in top repair, you will find the same kind of a thing, a patch seen over there and taking care of those pulmonic stenosis, either by balloon valvotomy or repairing that valve or fixing it up. Recently, I went to Colombo. You know what they did? They gave me a subject for evaluation where something was done at the age of 8 years and that lady is now 30 years old. And no prior history more than this. So I looked at that lady, 4-chamber view, everything looked good. I looked for a ASD graft, I looked for in the VSD in all inlet, outlet, short axis view, and then plaques window. I couldn't find anything being done surgically. Then I asked, did she get a chest like open surgery or a closed surgery? Now the question came, closed surgery. It means some intervention was done. Then I saw that the apical part of RV was showing heavily tuberculation, heavily hypertrophied RV with presence of a contrast, like you could see a dynamic obstruction in RV apex. And when I rotated my transducer at 90 degree to look at parasol short axis view aorta and put my colors in pulmonic valve, I found out that this lady had a pulmonic valvotomy at the age of 8 years. So that's how we try to look at all these things. We go all 4-chamber, 5-chamber, subcostal, plaques windows, and short axis views to look for something like which has been done before. And whenever something has been done before, that place would show hyperechoic imaging. Okay.
Thank you, sir.
Thank you, Nida. Dr.
Thank
Sai Prasad. Manu Kapil. Dr. Clay from Tanzania.
Sir, no question, sir.
Okay. Anybody else who's left behind? They want to mark their attendance.
Sir, here Tushar.
Tushar, any question? I took your name in the beginning itself. Possibly you were not there at the time. Anyway, any question, Tushar?
Hello.
Anchula, go ahead.
Good evening.
Good evening, Anchula. You're taking
Questions, sir.
care of
I have
your
to
kids,
repeat
you
a
know.
lot. Sorry, sir.
Any questions, Anchula?
Hello. No, sir. Thank you, sir.
You're taking care of a good kid's mom, yeah?
So I'm doing everything at one
Yeah,
time.
all in one.
Yes, sir.
Good. God bless you, beta. God bless you. Anybody else who's left behind? Rakshit, are you there? Dr. Chandan Kumar Roy Mahapatra. You
Sir, good
joined
evening,
very
sir.
late, Dr. Chandan.
Yes, sir. Sorry for yes, sir, because I have reached to my home in the late. So I tried because.
Any question, Chandan?
Sir, the only question actually there is a very complicated question whatever. But my question is, sir, to the DRV and tetralogy of Haller. So the between how this is a clinch point to just a single point which will identify and.
So I think the question from Chandan Kumar Mahapatra needs a little different answer. So give me a second. Let me take out a case and then that will be the right answer for showing his answer, right? So give me a second. It may take a while, Chandan, because the formats of slide is very old. And to convert this format of slide to back to normal, it's going to take some more time.
Okay, okay. Sir.
All right, so we got it. Let's see how does we behaves because it may behave awkwardly, but we'll try to manage. I hope you can see my slides now.
Yes, sir.
All right, this is what I wanted to show you. Fortunately, the picture got fixed. This is LA, this is LV, this is interventricular septum, this is RV. Look at this septum over here. This septum is overriding the aorta. is almost 50% override of aorta is seen in this septum. Now this is touchwood is playing very well. Oh, it's gone. Can you see this overriding of aorta? This is overriding of aorta.
Sir, yes, sir.
So if you happen to see this kind of a VSD with associated RV hypertrophy with pulmonic stenosis, this is what the tetralogy of Fallot is.
Sir.
And majority of these VSD, they are very large. They are not small VSD. They are large VSD, and there is a chamber pressure equalization in these VSDs. Okay.
Yes, sir.
And one more case for possibly Dr. Nida Khan, if she is there. Nida, are you there?
Yes, sir. Yes, sir.
I could locate one patient who has been done tetralogy of Fallot repair. Post-operative TOF. Can you see my slides?
Yes, sir.
Look, I'm going to show and then freeze them up, these slides, because they are going to disappear. Look, this is a patch which has been done in tetralogy of Fallot. So I'll play it again and again because this format is a very old format. Look, it's a hyperechoic shadow in the tetralogy of
Yes,
Fallot.
sir.
This is what the patch is. Okay. Now what has been done to pulmonic valve? This is a second question. Because all this tetralogy of Fallot will have pulmonic stenosis. So pulmonic valve was taken care of in this patient. What we see only one septal leaflet and other leaflet is not seen at all. So what happens? You have a torrential pulmonic regurgitation in this. The patient is presenting with torrential pulmonic regurgitation. Only one septal leaflet is seen. Is that clear?
Yes, sir.
And this is what you find majority of time. Now look at this, the color flow in this patient. So free floating PR is present in this patient. So we look at these kind of a things and then make a diagnosis, and sometimes like we have to go back and find it out why these things are seen. Look, it's not seen in inlet portion. It's only seen in outlet portion. Again, the same thing. You can see a patch, a hyperechoic patch. Okay.
Yes, sir. Thank
All
you,
right.
sir.
I'll stop it over here. Then anybody who's left behind. Okay, if there's no more question, shall I say good night? Shabba Khair, stay safe and see you next week with the question answer sessions. Not from my side. I'm going to ask you question answers. So get ready next week. Yogesh,
Yes.
you want to ask something?
No, sir, but And we'll have to be ready for next week question answer session.
Yeah,
So,
just go through those recording, you.
yes, sir. Yes, sir.
Dr. Pawar.
Yes, sir. Pawar, go ahead.
Sir, I was here, sir, when you called, but I couldn't connect with the audio.
All right, Pawar, I'll do that. Pause it, please. Mark you present, right?
Thank you, sir. Thank you.
Right. Okay. I'll stop over here. See you. Good night. See you next week. Bye-bye.
Good night, sir.
Good night.
Good night, everybody.